Good morning, and I'd like to say welcome to all our respectable colleagues and guests. We will start with talking about the subscapularis tears. I have no financial conflict of interest to disclose. Recognition of the subscapularis tears and definition of the repair advanced with arthroscopic techniques, and most of the data we have is from the last 15 or 20 years. Subscapularis originates by covering almost the entire anterior surface of the scapula, and it's the strongest cuff muscle, as we know, and its function depends on the position of the humerus. By forming a force couple with the posterior cuff infraspinatus, it supports the stability of the glenohumeral joint, and in anatomic position, it internally rotates the arm. Considering the rotational vector, its compression effect is more dominant on the abduction, and it helps deltoid to function properly. In conjunction with that different functions, the upper part of the subscapularis, which insert as a tendon to lesser tubercle, is innervated by the upper subscapular nerve, and lower part is innervated by the lower subscapular nerve. During arthroscopy, we can see the upper 1/3 of the tendinous portion of the subscapula from the posterior. This is a cadaver picture, and this one is from the arthroscopy. Upper third of subscapularis creates the anterior portion of the biceps sling, along with coracohumeral ligament and superior glenohumeral ligament. These two ligaments and biceps tendon are strongly related structures, and their problems accompany the subscapularis tears. If the subscapularis is torn, we see anterior dislocation of the biceps frequently, and that's why we see isolated subscapularis tears rarely. This is an arthroscopic short video. The evaluation of the biceps tendon is very crucial. We should double check the subscapularis tendon in cases with the biceps tendon problems, even if we don't see any problem of the subscapularis in preoperative imaging or physical examination. And this drawing is for demonstrating the intricate anatomy of these structures, supporting the location of the biceps in the groove. So with the torn subscapularis, we also see problems related with the biceps tendon, especially instability. Isolated tears are very rare. The most important reason for that may be they don't cause significant problems, significant symptoms, and they don't require surgery. Thus, maybe they are remained because of that unidentified. We used to think that subscapularis tears also not so frequent. In 1992, as you see, 8% of the 8% of rotator cuff surgeries only they were reported. But as the years go by, the frequency is increased up to 50%. Also, the accompanying lesions are biceps problems frequently, and slap lesions and superior cuff lesions. This is an 8-year-old study from our team. It's shown that slap lesions, biceps tendon problems, and superior cuff tears are very common in subscapularis tears. And this is from the end of the last year. Still in 1,600 subscapularis tear cases, 85% of them have superior or posterior cuff tears. Also, out of more than 2,000 rotator cuff tear cases, 42% of them have subscapularis tear. So there is an increasing trend in our database as well. So how these tears occur? Generally accepted that tears are commonly a result of a functional problem and intrinsic degeneration rather than a mechanical impingement like the superior and posterior cuff. Rarely, the tear may occur with a trauma, and sudden contraction against the resistance may be the mechanism of that. And in elderly patients, we can anterior dislocation may be the mechanism. There are mechanical theories also, but they are not new. A coracohumeral distance of less than 6 to 8 millimeters is considered as a factor. A rolling ringer effect is suggested. The old school laundry dryer machines. Its mechanism is explained with this one. Coracoid tip is pushing anteriorly to subscapularis, and attention is created between the coracoid process and its insertions on the subscapularis tendon, especially on the articular side. And tough lesion, tensile undersurface fiber failure is defined. As you see here, the posterior part of the subscapularis tendon is hyperintense. So in this mechanism, it's suggested that the tear is started from the posterior part, the articular surface, and the superior part. So that's why that may be the reason for the recognizing these lesions with arthroscopy. So there is a problem with the coracoid morphology, but we don't know exactly what's it. According to another study of our team, there is no difference in terms of coracohumeral distance in subscapularis patients and the ones without subscapularis tears. Also, some authors say that firstly the tear occurs and then the humeral migration occurs. So we don't know which one is the first. So it's like again chicken problem. In the same study, there was a powerful correlation with the coracoid overlapping, but we don't know the exact cutout for that, the lateral overlapping of the coracoid process beyond the glenoid surface. Either way, we believe that there is something related to coracoid morphology, but we just believe that. We just don't know what is it exactly now. We have some physical tests which are not highly sensitive, but some are specific. On the left, we are seeing the lift-off test. The patient placed the hand on the lower lumbar spine and pushes anteriorly against the resistance of the examiner. Internal rotation lag test is also performed in the same position. If the wrist moves anteriorly while we are holding the elbow of the patient, it's positive. We use belly press test, the middle one, more commonly in these days. Patient press on the abdomen against the resistance, and belly off test is similar as the mechanism to internal rotation lag test. Beer hug test, the right one. Patient press on the contralateral shoulder, and while the arm is elevated to 90 degrees, he or she should remain this position. This is more sensitive and specific, but it's more important that the combination of beer hug and the belly press test, these two tests, is the most successful couple in the diagnosis, and in combination their diagnostic power is close to MR imaging. So there may be other problems as well related to accompanying problems. In radiology, most of the radiologists still do not report subscapularis tears, but there are things we should look for. We can see the impingement of the coracoid process. Of course, we can see the disruption of the continuity. The contour is disrupted, the subscapularis tendon's contour. Biceps tendon can be dislocated. In neglected cases, we can see the subscapularis atrophy and fatty infiltration. But even if we don't any of these signs, those findings, we might see subcoracoid effusion in T2 oblique sagittal sections, and effusion in superior subcapsular recess is a highly sensitive and specific sign of it. Cyst on the lesser tuberosity, lesser tubercle, similar to cyst we see on greater tubercle in superior rotator cuff tears. And in the same study, we see that there is no relation between these cysts and decreased coracohumeral distance. After the diagnostic process, we have lots of things to look, but it's still not 100% reliable. still whether we see something or not, we should look for the signs during the arthroscopy as well. If we can't see the subscapularis tear, we cannot fix it. The first arthroscopic clue is the coma sign. It's actually the retracted subscapularis pulling the superior glenohumeral ligament and coracohumeral ligament. It's the anterior end of the rotator cable. You should be seeing it here. A vertical curtain-like fault is observed, and this curtain is actually the footprint of the subscapularis tendon detached from its insertion. We should not be seeing it after the repair. Airbag sign is another one. It's the fibrosis occurred with the healing of the intratendinous tears. However, this is a very rare finding. Sentinel sign, defined by Lafos, degeneration and fraying of the anterior border, anterior edge of the biceps tendon. We should think about a defect in the sling function of the subscapularis when we see this sign, and it shows the chronic instability of the anterior biceps anterior chronic instability. This one is described by our team Farlock sign. It's the degenerated and frayed tissue, but not the biceps tendon. It's the superior glenohumeral ligament and coracohumeral ligament fallen on the humeral head. It's especially useful in the absence of long head of biceps tendon. Also, there is a maneuver that we can use to identify the extent of the tear. Subscapularis is elevated of the lesser tubercle with this maneuver, but we need when we push from that side, but we need a 70-degree scope for that. Lafos classification is the most commonly used classification for subscapularis tears. We most commonly see type 2 tears. It's the full thickness tear of the upper 1/3 of the subscapularis tendon, and more than 90% of the tears are actually occurs in the upper 2/3 of the tendon. These first three types mostly benefit from a simple repair, no need for extensive releases. In type 4 and 5, there is a muscle atrophy and fatty degeneration. If the atrophy is less than 50%, according to Coutelier classification, it's type 4. If it's more than that, it's type 5. In type 5, even we were able to repair the tendon, it would be still unfunctional, so we should be thinking about the tendon transfers. We see different grades of tears according to Lafos classification here. We are looking from the posterior portal in all of these. The first one is type 1, upper 1/3 partial thickness tear. The second one on the right upper side, upper 1/3 full thickness tears. In type 4 tears, there is a full thickness tear, and retraction and fatty degeneration can be seen on MRI, as we see here, but it's less than 50% of the muscle mass. Arthroscopic subscapularis tear repairs. We know that in combined rotator cuff tears, subscapularis should be repaired first, because when we repair it, the edge of the superior cuff tear comes laterally, and if we don't repair it, a greater tension will be placed on the superior and posterior repaired cuff structures. In this cadaver picture, we see the strong relationship between the subscapularis and the superior cuff tissue. There is a coracohumeral ligament in between them. There are also authors claiming that tenotomy or tenotosis can be performed directly, because they say that if the scapularis is not intact, biceps is not stable, so you can just do it. The coracoplasty is not supported by the current literature, routine coracoplasty, and acromioplasty is just for the superior cuff tears if it needed. We prefer posterior portal as our weaving portal in lateral decubit position with the shoulder interaction. 30-degree arthroscope is sufficient in most of the cases. If we need a greater weaving angle to the inferior parts of the lesser tubercle, we can use a 70-degree scope. Anterior portal is generally our second portal, and a probe is sent through it to examine the subscapularis. Anterolateral or lateral portal is used for the debridement, tendon mobilization, and preparing the bony bed. And anchor is placed through the anterior portal to have a perpendicular angle. We see a type 3 tear here. The debridement of the footprint is really important, and if necessary, the tendon stump of the tendon. One anchor, suture anchor is generally sufficient. There are 2 sutures loaded to it, and the first one is passed. After that, we should not be seeing the footprint or the comma sign. The second one is passed from a bit more medially to have a tension. If the tear is larger than 2 or 3 centimeters, 2 anchors may be needed, but a single row usually yields a similar outcome, and the tear rates are usually similar with single row repair. Coracoplasty has lost the popularity in the last years because the latest data showed that the coracohumeral distance is not directly related to tear etiology, and the repair outcome is not differing according to coracohumeral distance. But it can be still performed in the presence of an obvious joint bony structure or significant impingement. First, we excise the rotator interval, then we see the coracoid process. Its thickness is about 7 to 8 millimeters, so we should not resect more than 3 to 4 millimeters of it. We should preserve the conjoint tendon and be careful about the brachial plexus. Overall, the outcome of the subscapularis tear repairs is similar to superior cuff repairs. As highlighted in this study, unidentified or untreated, neglected subscapularis tears are the reason for the 40% of rotator cuff repair revision surgeries. And due to fatty infiltration in these neglected subscapularis tears, success of the revision decreases to 75%. The most important thing about the subscapularis tears is identifying the tear. If we are not performing subscapularis repair in 20 or 30% of all our rotator cuff repair cases, it means that we do not see it, we miss the tears, but the tear is still there. We should really keep a keen eye on these clues to catch the tear and perform the appropriate repair, which is mostly not so challenging. Thank you for your attention.